In 2003, when we started, the epidemic was concentrated. What that meant was, geographically, 2/3 of the infections resided in 6 high-prevalence states. It also meant that, in terms of populations, the highest risk groups were transgenders, sex workers, men who have sex with men, and drug users.
So in 2004, the foundation identified World Health Organization and FHI 360 as its primary STI capacity building partners. Their mandate was to provide technical assistance and training support to our STI technical officers based with the state lead implementing partners.
Quality of medical care is so inconsistent, we had to standardize the service offering across the 6 states that we worked in, while still allowing room for flexibility in implementation.
So the challenge we had is, how do you give our partners who actually execute the freedom to innovate on the ground, to be flexible, and yet manage some key fundamentals. So we came up with this idea of a common minimum program, which set the basic guidelines of what we would do, but still give flexibility.
So in the context of STIs, the common minimum program focused on an essential package of STI clinic services, and these included syndromic case management, treatment for asymptomatic STIs, periodic screening for syphilis, and also focused on ensuring service quality across all STI clinics in Avahan.
The process of syndromic case management was helped by the use of standardized prepackaged antibiotics. The STI drugs are color-coded to correspond to the different syndromes. Color coding helps overcome the problems of low literacy levels in patients and doctors' lack of access to written medical records for these patients. Another approach to treatment is presumptive treatment for asymptomatic infections. This was carried out for all most at-risk populations during their first clinic visit and was then repeated once every 6 months. The other component of the CMP that helped standardize systems and services across all the clinics was the COGS, or the Clinical Operations Guidelines and Standards.
The COGS document was the Bible on which we established all the clinical services for Avahan, and we used this standard for structure of the clinic, the basic infrastructure required, the universal precautions, syndromic management, what are the different syndromes for STI, and how you do the documentation and monitoring evaluation.
Even though the standardization was done, there was enough flexibility given for the local NGOs to mold the program according to the needs of the community to reach maximum number of MAPs for STI provision.
During the initial stages of the program, we found that there was a great fear among the community to undergo internal examinations, be it a speculum examination or a proctoscopy. So we had to address this so that we allay their fears and they come in comfortably for undergoing internal examinations. This we did by making some short films using our own doctors to show them that it was a very easy procedure.
Avahan also knew that simply having a conveniently located, fully functional clinic did not mean that the MAPs would come in for checkups. This is where the outreach workers became indispensable.
Training was provided to the technical officers of the SLPs, who in turn transferred it to their local NGO partners.
They are the ones who bring their community members to these clinics.
The initial challenge was that most of our frontline workers were semi or non-literate. We took this challenge to the community, and they themselves came up with this innovative idea of using pictorial cards.
The STI program was also responsive to the needs of the clients. See, for example, we found that even after the doctors had been changed, when it actually came to working with transgenders and MSM populations, there was some degree of mutual embarrassment between both the clients and the physicians. Moreover, the healthcare providers were also quite uncomfortable using the kinds of language that the communities themselves use to describe their sexual practice and sexual behaviors. So with additional training and sensitization, we were able to build trust on both sides, and the actual usage of STI services went up significantly.
As a follow-up to the training, we also made supportive supervision visits to the Avahan clinics to measure the quality of services.
So there were significant barriers which our communities faced in accessing STI clinic services. Some of these were like confidentiality issues, distance from where they are based, And also timings. Most of our community members work through the night, and it's very difficult for them to attend STI clinics in the morning at 9 o'clock or something. To address these challenges, we established different types of STI clinic service delivery models. So for example, we had static program run clinics which were based just next to the drop-in center. Community members could come there anytime and get a screen done. There were also outreach medical visits and health camps.
As the program was scaled up into semi-urban and rural areas, we asked the local NGOs and the community members to identify private practitioners who would be able to provide STI services. So these preferred providers or the local government healthcare facilities were used wherever there were a less number of community members, and the peer educators were asked to refer the cases to these facilities.
And now they are very freely come and approach me and also the staff. They feel that their own clinic, they feel it is their clinic also.